Thank you, Gianfranco. These are my disclosures. Right, so we've had some really interesting talks about nighttime blood pressure and or nocturnal hypertension. And I hope this afternoon you're all still awake, though, but because I think after lunch people tend to lose a bit of momentum. But what is important when we look at nighttime and 24-hour blood pressure is clearly the nocturnal hypertension profile is really very important. I know this was shown by George, and I'm glad that he showed this slide, because I just want to confirm here again the difference in the strength of the relationship between clinic blood pressure in black to nighttime blood pressure in blue. And this is with all-cause mortality. As was said, it's 6 times more value and informative. If you look at cardiovascular mortality, the lines are even more steep, right, for nighttime blood pressure and cardiovascular mortality. So if we look at this, it's very clear from several studies, a long time ago already until more recently, that nocturnal hypertension is related to all-cause deaths and cardiovascular deaths. And if we then zoom in a bit, also in the results from the J-HOP study from Japan, is that nighttime blood pressure is not only associated with total cardiovascular events, but specifically with stroke events and coronary artery disease events. So very specific in terms of these outcomes. Another review on nocturnal hypertension showed that it's also very strongly related to heart failure. And several of the studies that were included in this review included this one study, for example, by Professor Cario, showing that nocturnal blood pressure, or extreme dippers and non-dippers, as you can see in the red and yellow lines, are strongly associated with heart failure. This was also shown several years ago already in a previous study showing a non-dipping pattern is associated with heart failure. So that's another important outcome of nocturnal hypertension. If we, as you've heard, the topic is a bit about AF as well, atrial fibrillation. And if we now look at atrial fibrillation in itself, there's also some strong evidence for atrial fibrillation. And in these lines on these different graphs, it's by age group. As you know, that atrial fibrillation incidence is much higher with increasing age. So per age group, from the brown line down to those older than 50, you can see at all ages there is a strong relationship with cardiac hospitalizations, MI hospitalizations, and heart failure hospitalizations. So for AF, this is also important. Another study showed, and it's what I've mentioned before here on the left, is that AF incidence increases with increasing age, as well as the prevalence, and you can also see in terms of the deaths. So AF is also very strongly associated with all-cause death and with cardiovascular outcomes, as well as burden of disease. So if we then also look at atrial fibrillation and zoom in a bit into this Danish study, which is very interesting, finding also a very strong relationship between AF and, independent of the index age in the different boxes, is 45 years, 55 years as the index age for atrial fibrillation. It's always very strongly associated with the blue line, which is heart failure. And you will see the pink and purple lines is ischemic or any strokes. So the most common complication was heart failure for those with atrial fibrillation, followed by stroke and myocardial infarction. So once again, quite similar to what we see for nocturnal hypertension outcomes. And especially stroke and heart failure are quite key in both of these. So we know, however, if we just look at the association between blood pressure and atrial fibrillation, that hypertension is one of the strongest contributors in terms of risk factors for the development of atrial fibrillation, and that's why we know that hypertension develops from early ages onwards, but AF often have the onset only from later in life. And that's why also it would make sense, as was said in this recent paper in Circulation, and a collaboration between hypertension and screen collaborators, the AF screen collaboration on hypertension and atrial fibrillation. How can we do better screening for both of these conditions, as they are so strongly related in itself, but also in terms of outcomes? So the key risk factor for the development of atrial fibrillation is high blood pressure or hypertension. But now is the question whether nocturnal hypertension is a stronger predictor of atrial fibrillation than daytime blood pressure. And this very interesting study, which was already published in 2018, showed, on the right hand you can see it's quite a large number of participants, almost 4,000, and for 2,700 of these participants underwent 24-hour ambulatory blood pressure monitoring, and they had ECG data to determine whether whether there's a link between daytime or nighttime blood pressure and the development of atrial fibrillation, and clearly show here, interestingly, that there was no increased risk with nighttime blood pressure and AF development, but for 24 hours, there's a 27% increased risk for AF, and then 22% and 20% for daytime and nighttime. So overall, blood pressure is important in terms of atrial fibrillation risk, with not necessarily for nighttime having an increased risk, as we've seen for many other conditions. And there is obviously a very strong relationship. If you think physiologically, what happens when you have high blood pressure, as was shown in this paper that lays out the potential mechanisms with high blood pressure over a long period of time, resulting in increased left ventricular wall thickness and stiffness, diastolic dysfunction, and in the end, left atrial enlargement and cardiomyopathy, which then is a risk for development of atrial fibrillation. So there's a clear cascade that develops over time, particularly when you have high blood pressure from young ages onwards and hypertension is uncontrolled. And as was shown also, they share so many risk factors. So in terms of obesity, genetic predisposition, sleep apnea, inflammation are all risk factors for hypertension, but also for atrial fibrillation. Hypertension leading also then to the development of atrial fibrillation, and we have many of these shared outcomes in the bottom box there. What is also of interest is that if blood pressure is well controlled, as in this study shown intensive blood pressure control, there's a lower risk for the development of AF. So that should be a logical result, but it is very important that this has been shown. So again, emphasizing the importance of detecting high blood pressure and controlling it. Right, so we have established all of these relationships now, and the key thing I think that we should take home is the importance of detection of high blood pressure, detection of atrial fibrillation, and early management to ensure that it doesn't result in this long cascade of cardiovascular outcomes that we see. So the screening for both high blood pressure and AF is essential. And the key for that is, of course, both are asymptomatic. So it's not something that the patient would often come to a clinic for, and if it's not detected, it can't be managed. So in terms of screening for both conditions, of course, screening for AF is not recommended for all adults, as is the case for hypertension, due to the lower numbers. So it's a bit more tricky in terms of screening for AF, and the debate continues. Because screening is costly for large population studies, it is wondered whether there should be targeted case finding, who should be screened, because it's asymptomatic. So there's several trials ongoing to determine what would be the best approach. But at the moment, the World Heart Federation roadmaps recommend opportunistic screening for AF with pulse check or ECG in those 65 years and older, and hypertension in adults. So just a brief update on what we have experienced with My Measurement Month initiative, where there's a sub-study where we did some screening for atrial fibrillation together with hypertension. I'm sure most of you are by now familiar with what May Measurement Month is, but it's a global screening campaign that we launched in 2017 as part of the International Society of Hypertension. Millions of individuals have been screened to date, but in 2021, it was decided to do a smaller sub-study and to do concurrent blood pressure and AF screening. It was piloted in a subgroup of countries, and in 2023, we had 14 countries which participated. What we've done in these studies was to include specific devices, such as these OMRON models, which can include screening for AF together with blood pressure, so that it doesn't take any additional time and resources, but it's basically two in one. And so we've, in all of these countries listed, these devices were used. And we also collected additional information from participants about AF, whether, firstly, whether it was detected, obviously, and then also whether the participant have previously had a diagnosis for atrial fibrillation. And just very briefly, the numbers obviously is much lower than what we would typically see for hypertension, but clearly an age relationship there where we detected more individuals from 60 years onwards with AF. So, how to screen for AF, and I would like to acknowledge again Konstantinos and George's work here in their team on atrial fibrillation screening in this very interesting systematic review and meta-analysis on different devices, automated office, home and ambulatory devices, for using these devices for screening for AF. And so they evaluated several studies. And I think what's really relevant there is that it is recommended, as we know, and that these devices, which are already widely used in clinical practice for the diagnosis and management of hypertension, can also be effectively used at a low cost for highly accessible tools for also screening for AF at the same time. So there's good reliability in using these, and I think implementing them is an easy way to actually do both in clinical practice, but also in terms of home devices. Several measurements or devices can be used for screening at the patient level, healthcare level, for outpatients and inpatients. We have lots of wearable devices and phone apps that can these days also help detect AF, but also for home devices, the oscillometric cuff can obviously also do 2-in-1 blood pressure and AF, as well as in the clinic, together with ABPM. And that's why there's no need for additional time if there's already one device that can measure both, as was also concluded in this study. So let me conclude. It's not really to screen or not to screen. It is how is the best way to do this. And I think there's been a lot of uncertainty and additional measurements in terms of ECG that were done before, not as if this is a method that will replace ECG, but in terms of crude screening, it's a very effective way of using time to detect those at risk. So who to screen? As I mentioned, according to the latest guidelines, opportunistic screening for both AF and hypertension are recommended in people aged 65 years and older. Or however, if you have a device that can do both, it can be used in everyone. And as for also for AF in patients who already have hypertension, it's important to do screen for AF because they obviously have increased risk already, and other comorbidities such as sleep apnea, prior MI, heart failure, COPD, CKD, obesity, and diabetes all put them at an increased risk also for AF. And of course, traditionally by pulse palpation, ECG is a standard and routine way of doing this, but it's not always possible to do it for all in primary care. And then, of course, AF detection algorithms in validated cuff-based monitors is indeed appealing to also save time. But we need to still, for AF screening, do more research in terms of what's the most effective approaches. And I know the AF screen group especially is particularly spending quite a bit of time on finding the best strategies to implement. Thank you.